Good afternoon, everyone. Welcome to our webinar panel today. A lot has obviously changed over the last 3 to 4 weeks. So today we're going to be talking about and hearing from some revenue cycle leaders about their experiences and how they're handling everything that's rapidly changing and developing related to COVID-19. As you can see, I'm working from home. Greg's working from home. Usually we're in the office doing these together, but obviously times have changed, a lot of uncertainty going on right now. So we hope that this session can give you some ideas around how to best manage this. So I'm going to pause for just a few seconds just because I see a lot of people still dialing in, and then we'll go ahead and get started with introductions. All right, well, let's go ahead and get started. We're a couple minutes past the hour now. So we'll start with introductions here, and try that again. Bear with me 1 second while I get our slides going here. Okay, sorry about that. Not sure what happened there with the slides. So let's go ahead with introductions. So 2 revenue cycle leaders have decided to join us today, which we're incredibly thankful for with everything going on. So our first panelist is Samantha Evans. She is the Director of PFS and Patient Access at ANMED. So Samantha, tell us a little bit about yourself, and you would just a little bit about ANMED, where you guys are located, and kind of what's going on with your community right now.
Sure, thanks for having me. As he mentioned, I'm Samantha Evans, and I'm the Director of Patient Access and PFS at ANMED Health. ANMED Health is located in Anderson, South Carolina, and we are the largest independent not-for-profit health system in the state. We have 2 locations. We have our main campus, which houses about 460 inpatient beds, as well as our ED department. And then we have a North Campus, which is our women's and children's location, as well as our cancer center, which houses the majority of our outpatient services, obviously labor and delivery, and our cancer services. And so just like everyone I'm sure on the call, we have been scrambling to get those who can work from home, working from home, and get as many hands on deck at the hospital locations that we can. So looking forward to just talking through some things that have worked and some challenges that we've seen over the past couple of weeks.
Awesome, thank you. And then Sheila Morris is the Director of Revenue Cycle and PFS at the Shepherd Center. Sheila has managed and consulted for 30 years within hospitals, and she's been at Shepherd for 2.5 years. So Sheila, welcome. Tell us a little bit about yourself, and if you could, a little bit about Shepherd.
Thank you, Brad. Hi, everybody. The Shepherd Center is based in Atlanta, Georgia, founded in 1975. We're a not-for-profit LTAC specializing in catastrophic rehabilitation, medical treatment, research. We initially began in 1975 treating spinal cord injuries. We still do that, as well as brain injuries, MS, pain, neuromuscular conditions. We treat patients from across the country and globally. We have an ICU unit, 152 beds. We have specialized day programs and outpatient services designed to meet those patients' needs.
Great. Thank you, Sheila, for being with us today. And then last but not least, Greg Kay is with us. Greg has been with PMMC for 20 years now, and he really is our subject matter expert. And so with that, I'm going to turn it over to Greg to tell us a little bit about what's going on today in the industry with COVID-19.
Great. Thanks, Brad. And first, let me add again how much we really appreciate Samantha and Sheila making time to share their experience over the past few weeks as they've transitioned to a new normal for their revenue cycle processes. And really kind of before we move into the panel discussion, I would like to share that we'll be making a donation to the United Way Coronavirus Relief Fund in their honor. So Sheila, Samantha, thank you again for making the time to do this today. So in terms of the industry, I found this article last Wednesday. It was by JP Morgan, and they published an article noting that the recently passed stimulus package may not be enough to outlast the current projected economic downturn. And while the impact of the coronavirus is still the daily headline news, and many of us have personal friends and associates that have been infected or maybe dealing with this situation. From a business perspective, the economic impact for hospitals is really going to come down to the drop in elective procedures that really appear to be steeper than many initially expected. And this shift will likely end up putting financial pressure on hospital business offices to be as efficient as possible to maintain cash collections. And as revenue cycle leaders, our challenge is really to maintain the right tasks today and to anticipate future challenges that are still out there in front of us. And over the past few weeks, as we know, many organizations have shifted staff to work from home, and this includes both providers as well as payers. And the reduction in elective procedures has, in some ways, been a little bit of a blessing in that it's allowed many organizations to maintain key baseline activity metrics as we've gone through this shift, but it will likely lead to lower cash collections in the coming days as that shift kind of works its way through the process. The unknown component that this article points out is really how long the duration from the downturn itself may last and what's the related financial impact. I think that's the unknown piece that we're all thinking through and are concerned about each day, each week as we go forward. One thing that I have heard from friends that are in the industry as it relates to medical device manufacturers, pharmaceutical companies, physicians, they are planning for a time when elective procedures will pick up, and they're wanting to project and look at what things will look like when those procedures are 20% above normal projections versus the current 20% below in many cases that they are today. So it's going to be prudent to be sure that all collectible cash is collected today during these slower periods. And we have to begin anticipating how to handle these increases in billing and collection volume that will likely come later when things do improve and the elective procedures that are being postponed today do get rescheduled. So just in terms of a state of kind of where we are, I did want to share that perspective.
Thanks, Greg. I think that was a good way to kind of set the stage and open things. So now we're going to start talking about some of the revenue cycle challenges that hospitals are facing right now, since this is all really come into play. So Samantha, I'm going to start with you. Have your teams transitioned to a work from home environment? and kind of what's the current status around that?
Sure. So as far as the back office, which I consider billing, follow-up, cash services, we have 93% of our folks at home. So we kind of rolled it out in increments. We sent the easy ones home first. Easy meaning the majority of their job was done in Epic through work queues, and they really only needed either a computer and internet or really already had those two things, and we could just provide the remote login to their computers at their office. So that was a pretty easy transition, both for billing and follow-up and really even cash services. The other two departments that are housed in our business office was financial clearance and first call, who's our scheduling department. Well, those folks talk to patients all day, every day, either because they're scheduling things or financial clearance was calling them with their estimate, their out-of-pocket, pre-regging those patients. So we kind of had to work with IT to say, okay, what can we do to not allow their cell phones to show up when they're calling patients, or if patients are calling into their extension, how can we get that to forward to their home? So we were able to work with IT on an app that linked to their office number. So either when they call out or patients call in, it does show that AMED helps. So once we got that configured, we had everybody in the back office really at home, outside of 2 or 3 that just do things that really can't be done outside the office. They either were doing the mail and having to mail the hard copies to turn into electronic 835, or they just had equipment such as scanners that was indexing things to the patient charts that, again, we just couldn't make happen at home. So I say that to say that the majority of the back office, they are at home working well, no big known issues. But as you mentioned, I'm also over patient access. And so that has looked a little bit different as well. Of course, they're on the line, still registration and admitting, but those things have changed as well. So usually we collect in the inpatient settings, we get the form signed. We have gone to phone only at this time. We're working with the nursing staff to send any forms up that they can get signed for us. We're calling the patients to talk about their out-of-pocket, their insurance, that sort of thing. And then lastly, our financial counseling, who also rounds in the inpatient setting on our true self-pay patients, have also moved to phone-only interviews. We implemented a new software this year that they're also able to do that from home. So we do have some still located at the main campus, but still making those phone interviews. But we do have some of those folks working from home as well. So I think later we'll talk about some challenges that we've seen, but that's kind of where we are right now.
Okay, great. And Sheila, how about at the Shepherd Center?
A similar experience, Brad. We've moved staff to working remotely as well, and we started with that low-hanging fruit. Had a lot of people who were already internet savvy, had the equipment, so that was an easy push. We also have jobs that are dependent on scanning and paper and posting some paper remittances. Those have been a struggle. Those folks are rotating in. They have alternate schedules, and we've tried to stack as much work as we can so that they get as much remote time as possible, or have hours where, and distancing where they're not together. We've spread people out. Some of our front-facing folks are still here, even though we have closed the majority of our elective outpatient services. But we do have some front-facing people still, and we've spread those out. We have redirected patients for appointments in a lot of cases in order to achieve that. We're also an Epic facility, so we've been able to use work queue monitoring primarily. We also have some various reports and some manual logs for those folks who are paper-based or tied to a scanner, that kind of thing. We actually got a surprisingly great response to remote working. It's something I was a little lucky because we had talked about it amongst my management team 4 or 5 months ago and intended to test and roll out properly beginning January 1st, 2021. Of course, we had to ramp that up, but we had already built a little bit of momentum So our people are responding beautifully, and in a lot of cases, productivity has gone up. So that was actually a really nice thing to have happen. Our greatest struggles, I would say, are still with the printing and scanning and some of those attempts to ask payers to expedite alternative methods, whether it's secure file transfers, portals, et cetera. Those kinds of things are moving very slowly for change. I have some understanding and sympathy because of the change that they've gone through as well, but it is still a struggle.
Okay, thanks for giving us your perspective on that. And then since you guys are both responsible for front end teams as well as back end, with PFS and patient access being under your management responsibilities, how have those two groups transitioned to work from home? And then have you shifted any employee tasks from the front end to the back end? Samantha, we'll start with you.
Sure. So kind of how I mentioned, we don't have too many people on the front end at home yet, but we definitely have had to shift some tasks. So a big part of what our financial clearance department does is do a patient estimate out of Epic to provide the patient with their out-of-pocket costs for their upcoming service. Of course, they have to run the payment at their desk. We were not able to get any type of thing to work remotely for a credit card swipe. And so we went back and forth to say, okay, well, our self-pay vendor has a portal. Maybe they can log in and take the payment there. Then we ran into that wouldn't work when they didn't have a balance on the account yet. And so we had to kind of say, okay, at this point, if financial clearance has a patient on the phone, they've given the estimate and the patient would like to go ahead and make that payment, what does that look like? So we paired them up with our admitting team. Our admitting team, again, is doing phone only, but they actually are still located in our main campus. So we had to shift the task. We actually, from financial clearance, will have to transfer the call to our admitting team. And then a lot of the patients are just saying, hey, when I come, I'll pay. I don't want to have to call back to admitting, or I don't want to have to be transferred to admitting. So whereas we were seeing a lot of pre-service payments in our financial clearance, we're now seeing that shift, really even having to call back to admitting, or just when they're showing up for their service, we're seeing that. And really, we're seeing a decrease in point of service collections anyways. AMED helps put a big focus on that the last year or two. But as those services are decreasing, of course, we're seeing those payments also decrease. But just the unknown of patients with their job status and just different things that this is bringing, it has put a burden kind of on that initiative. But it is something that has worked well. We've worked with our admitting staff well. So that's one thing we have kind of had to shift from one area to another.
Okay, and then how about you, Sheila?
We did not shift workers from the front to the back, but because of extended wait times on the telephone, we have redeployed our front-facing people where the area is closed. We've moved those over to verification and authorization work. Fortunately, we do a lot of cross-training, so that was somewhat seamless. For those that are still front-facing, we're taking precautions. That includes not HIM folks that may pick up items from a floor. We did move financial counseling appointments to primarily telephone encounters and adjusted our availability for in-person meets. That includes HIMs, medical record responsibilities, release responsibilities. We are still doing some in-person work, but very limited as to who's in the lobby or how many at one time. In terms of self-pay collections, we do have some that are happening, very limited. We're trying to steer everything we can to telephone. We actually, because we have very long lengths of stay, our estimates tend to be larger for inpatients, and a lot of that work is done by wire transfer already. So we didn't have a lot of change in that respect. We've used a self-pay vendor for quite some time for patient portions, so I didn't have to adjust for credit card acceptance. We do have people rotating in and out to handle one-offs or special situations. So that's how we've adjusted.
Okay, great. Thanks for those responses.
Oh, and Brad, I'm sorry,
sure.
Brad. I should say that I've put forth a charity proposal to my CFO. We have already started to hear patients or families talk about loss of jobs and furloughs. So I've put an initial proposal out there and started to gather some information about that. I'm not sure if we'll expand our qualifications or criteria, or if we'll set a defined period of time for some additional leeway, but that's something that's on my mind as well.
Okay, great. So now let's talk about some of the best practices that you've learned. I know it's only been a couple of weeks, right? But what are some of the lessons that you've both learned as your teams have worked through this process? Things like equipment, connectivity, and a lot of what's going on is just balancing those home and life with work demands. A lot of, obviously kids are at home. So there's just a lot going on right now that people are trying to juggle and manage. So how are you and your managers, maintaining that personal connectivity with your team, and also managing kind of that work-life balance right now? Samantha, let's start with you.
Sure. So we have tried to emphasize business as usual as much as we can. So just a few examples. I have a cash services manager who used to huddle with her team at 8:15 every morning. I said, we have WebEx capabilities. We have so many technology things that are on our side. Continue with your huddle at 8:15. I had someone say, hey, I have a staff meeting next week. Continue with your staff meeting via WebEx. We're trying to point out that just because our location of work has changed doesn't mean what we do on a daily basis has changed. I'll actually mirror what Sheila has said. Our first 2 weeks, we were also 17% over productivity than what we've been seeing. So that was very encouraging that we have staff that we don't need to micromanage on an hourly or daily basis to make sure that they're doing what they're supposed to do. I will say that we did start as a management team looking at productivity on a daily basis rather than a weekly. So in the past, we had looked on Monday mornings for the prior week and kind of, address anything that needed to be addressed. Right now, managers are looking at it every morning from the day before, just to ensure there's nothing that needs to be addressed, no questions need to be asked. Hey, are you having trouble with your internet? Do you need additional training? Tell me kind of what's going on. I saw a little struggle yesterday. So it's not that we're micromanaging, we're just managing a little bit differently and a little bit, closer look, just to ensure that we don't let a week or two go by and say, hey, wait a minute, we had a few people with a couple different issues. So really just staying on top of the communication, I think, is key, making sure that if we need to all jump on a call, that capability is there. So again, we're not physically seeing each other, but there is technology left and right that we can use, and that is something that AMED Help has been able to use. We also have like an internal instant messenger thing. So it's literally like IM back in the day, the AIM. So we're able to just ask a quick question and get a quick answer back. So that has been really helpful in kind of getting quick answers. As far as kind of the work-life balance, AMED Health has always had some folks that have worked remotely, some in coding and So we've always had a work-from-home policy that it was much more strict than kind of what we're seeing now. It was, there could not be children in the home, and you had to have an office with a door, and the list just kept going. So they did kind of open this policy up, knowing that, to your point, kids were home, but we kind of set the expectation kids can be in the home, but if you're taking care of a child, 100% of the time, you probably can't also work 8 to 9 hours a day. So we did ask that they kind of work that out, but did not say, hey, you can't have kids in the home. So overall, it's been a huge success over the past 2 weeks. And again, I think the biggest thing has just been to remind them our location has changed, but what we're doing on a daily basis has not. Continue to ask your questions, continue to reach out. We're here, we're available. And then the last thing I'll talk about is the folks that are still in the building, we have a manager rotation. And so we're all in the office 1 day a week. And what we're doing is we're there to mail the hard copy claims, to do the hard copy appeals that can't be done. I know Sheila kind of talked about some of the struggles they had were with the printing and scanning. And so we're seeing those as well. But something that has worked well is having one manager on site to just kind of, one, oversee the couple staff that are there, but to also kind of fill the gap of, okay, I'm going to mail all these VA claims that have to go hard copy, or I'm going to go through the return mail to ensure it follows the bad debt process. So that's really worked well for AMED Health.
All right, great. And then Sheila, how about you?
Probably the biggest lesson learned very quickly was that staff will need support with their tech skills. Before we sent them out, we did some dry runs and had demos, but we have found it necessary to repeat. There have been some little snags along the way, even as of now. We already had our remote working policy in place because, like I had said earlier, we had started months ago. We have, as part of that the remote worker should not be the sole child care provider. I've taken the approach of erring on the side of kindness during this emergency declaration, or don't ask, don't tell, if you will. We're lucky in that respect. We haven't had a lot of issues. Overall productivity has been incredibly enthusiastic and surprising, a good surprise. We downloaded functionality so that we could forward calls and track activity. We did find that we had to do additional work. I think Samantha referenced this earlier in terms of automated call distribution, hunt groups. We had to do a little more work and testing to perfect that. We did find that it was better to send out some hard phone sets versus using audio via the computer in a few of those cases. Our managers are all hosting WebEx sessions. We've got everybody set up for that. Managers and supervisors are rotating. And I've asked my managers and supervisors not to forget the amount of stress and anxiety. So they're reaching out to individuals. I had them start with those folks that have special concerns. You know, we all know our staff. We work with them every day, so we know the ones that have special conditions and illnesses. So we've focused on those, but as well as meeting with the whole group. And what I have said to my team is repeat often, repeat as necessary. You can't emphasize communication enough, in my opinion.
Yeah, I completely agree with that. And I think Samantha's point about business as usual, as much as we can, is also important. So let's move on to our next topic, anticipated challenges that remote operations might bring to payer follow-up and collections. So during these times, a lot of healthcare providers and most payers have moved, 50 to 90% of their staff to remote operations. So what operational process challenges do you anticipate with those normal AR management tasks? Do you anticipate or are you seeing any processing delays? And then how are you addressing things like PHI requirements? So Samantha, we'll start with you.
Sure. So as far as the PHI, as we mentioned, we did not send any type of scanning or printing capabilities home. And so all of that is still being done in the office. Some of our follow-up folks do have the capability to fax from Epic, and so that has continued as usual. So the payers who allow appeals to be sent electronically were able to still do that. The appeals that have to go hard copy or just there's something different about it that they can't do, again, management will be in the office to be able to do that on a daily basis. But I think you make a great point. We're not the only ones that are getting used to a new normal. Our payers are as well. So just at AMED, we've gotten emails from Blue Cross and Humana and a couple more payers that they have also moved their staff remote. And so without us really knowing their processes, we really at this time don't know if them moving home and going to a remote location, if it will slow down processing. I think it's pretty early in the game. I will say we've seen a little bit of slowdown with Medicare. It's like we'll get a couple really low remits and then they have a catch-up day. And then we see a couple more days where not a lot of claims pay, and then we see a catch-up day. I would assume, since it's pretty, still early on, so to speak, it's been 2 to 3 weeks and we're already seeing that, I would assume that that's just going to be a longer and longer process delay. We have not currently seen it with any other payers, but I will say we've seen a little bit of slowdown in the answers of appeals, and when we reach out for questions, getting those answers back. And so not necessarily the payments have slowed down, but the follow-up. So if we're working denials and need to reach out for an appeal or a question, we are seeing some slowdown on the responses. So, I've preached to my team, we can do what we can do, and we need to control what we can control. As I mentioned, they're continuing business as usual. Their productivity is continuing to be hit every single day. But I do expect over the next couple weeks to kind of start seeing a little bit of processing delay with a few of our payers.
Okay, thanks, Samantha. And then Sheila, how about you?
Some of the same issues. We also are experiencing longer wait times. It's just harder to get somebody on the phone. It's harder to confirm that data was received for authorization purposes. We know it's because they don't have folks in the office like before. I think I referenced earlier that we have a longer length of stay for inpatients. It's just under 2 months. So a lot of times our volume, the size of the records we're sending, is just bigger. And that has been a bit of a struggle, especially for those payer or paper-based items especially. We've reached out to payers. It's been slow moving so far to try to get expanded capabilities or alternative methods. I'm still hoping for that. And of course, I prioritize by the largest payers for us. We're also rotating, trying to take care of those items that have to be handled in the office. I have done some things that may not be quite as relevant just because of who we are and the population that we treat. We are doing some arrangements that are in lieu of audit because we do deal with a lot of workers' comp payers. That gives a little bit of flexibility. And we also applied for the Medicare accelerated payments. It's a little bit early to tell you feedback on how that works. And of course, I'll hold my breath on the recoupment process afterwards. But it was available, so we filled out the paperwork. It's out there and available, so you might want to take a look at that as well.
Okay, great. Before we move on, I've gotten a couple comments through the chat that some people are having some problems with the audio through the web. I apologize for that. If you do have the dial-in in front of you, it might be best to dial in by phone. I've been on the phone the whole time and haven't had any issues, so I think it might be related to the web audio possibly. So apologize for any audio interruptions you're getting. We are recording this, so hopefully everything on the audio side is being captured in the recording. And if you are experiencing any issues, just go ahead and type that in the chat, and we'll get to it as we move through this. So apologize, Samantha and Sheila and Greg, for pausing and interrupting there. Just wanted to address that. On our next topic, on metrics. So Samantha made the point earlier about, keeping business as usual, right? So how are we monitoring metrics in a work from home environment, and which metrics are you all monitoring in this new normal? So billing activity, cash posting, denials, days in AR. So beyond the typical AR management items, are there any new items that you're planning to track and monitor? Samantha, how about you?
I go back to the business as usual. The same things that we've been reviewing on a daily, a weekly, a monthly, a yearly basis is what we've been reviewing over the past couple of weeks. So our CFB, our DNFB, our denial rates, our days in AR, and our aging. Now, granted, it's only been 2 or 3 weeks, and so really what I have focused on is ensuring that we're getting claims out as fast as we have been. Again, we can't control how fast or slow the payer is going to process those, but I've kept a big eye on the CFB and the DNFB, and I have seen that continue to go down. So we are continuing to get the claims out in a pretty timely manner. Also, aging, I think it's too early to tell, but that'll definitely be something I keep on my radar. We've had a big focus on that the last year or two at AMED Health to really drive down the 90 days and over aging, and we have spent so much time. So I am crossing my fingers that the payers don't ruin what we've been doing for the past couple years. But we'll have a big eye on that to ensure that that doesn't creep up. And really, if it does, we'll go back to, are we controlling what we can control? Are we billing claims, as quickly as we can? Are we doing our denial prevention initiatives up front to continue our denial prevention initiative at AMED Health? And so I know, at least on the CFO's radar, we're trying to look at cash and what that's going to look like. I've always had a cash method of our current month's cash flow and what that looks like with a 90-day, past review of gross revenue. We just don't know what the revenue is going to look like moving forward. We have, 2 weeks worth of data, and we can kind of see that it's trending in a certain direction. So do we, forecast it based off of the last 2 weeks? Do we think it's going to continue to go down? So I know that cash is going to be kind of a moving target and something that we continue to look at. But again, I go back to just looking at the things that we can control and tying it back to, are we doing our part and just continuing our initiative? So just because payers, have come out and said, hey, we're giving you some leeway on this authorization, or we're giving you some leeway on this, and this. I've told my teams, as much as we can, let's continue our regular processes, because I can see it now, and you guys deal with payers every day, so you know how it works. They'll say, hey, we're going to waive, authorization requirements for the next 3 months. And then next thing you know, in 3 weeks, you get a denial for no authorization. So my point to the teams have been, let's continue what we do. If something comes up and we're unable to do it and the payer has given us the leeway, that's great, but let's still do our part. And so to kind of bring it back to what I was saying in the beginning, it's going to be the same metrics that we've been looking at, with probably the majority of the focus being on aging and our cash.
Great, thank you. And Sheila, what are your thoughts on that?
Very similar. I have not changed any of the reports that I look at. Neither have my managers and supervisors. I'm primarily interested in cash and bills out the door. We have put a focus on coding throughput and cleanup to maximize everything that we can possibly get out the door. We do have a loss in revenue due to closing down services, of course, so that will have an impact on cash inevitably. We're trying to keep a close eye on fulfilling additional information requests, handling denial issues. One of the things that I did, and it's a work in progress, I started building a spreadsheet, a grid for payers and who's given relief or waiver and when did it start and through what period of time. Much like Samantha said, I expect to have some issues a little further down the road where we get denials for authorizations and that kind of thing. So we're trying to build a little library and spreadsheet to track where we should have gotten some relief so that we can argue about it later. But really, I have to say, for me, cash and bills out the door is always going to be the most important thing to keep an eye on.
Yep, great. So let's move on to our final topic here. So now let's talk a little bit about consistent cash flow over the next few months and really throughout the rest of the year. So we know that the current environment may change some hospital service mix with elective procedures being delayed and new treatment codes having to be billed. But let's just put that aside for the moment and just focus on the AR management process. So in other words, revenue cycle departments can't control what services are performed, but how those services are billed and collected. So any additional thoughts or plans that you're considering to ensure that consistent cash flow as you work through this transition? And we'll start with Samantha.
Yeah, I guess I'll just kind of mirror what we said previously in the previous slide. We are going to control what we can control when it comes to claims out the door and keeping business as usual as much as we can. I say that to say I think it'll be important that we track and trend. And so as we see this reduction in revenue, I love Sheila's idea of the library. I think I'm going to write that down and do that myself. But tracking and trend these payers that are saying these things. So again, if I have 10 or 15 payers that are saying, hey, we're waiving authorizations, but in 3 to 4 weeks, if 8 out of, the 10 payers are now denying me for authorizations, instead of calling and trying to fight, we go back and say, hey, I know what they said, but let's go back to getting the authorizations. And again, I'm preaching up front, let's never stop getting the authorizations, even though they say we can. Now, again, if we're trying to get an authorization and due to them not having enough staff in the office and that sort of thing, and we're unable to get it and it would hold up clinical care, obviously we would still allow the service and try to work with the payer on the back end. But it's all about controlling the upfront. And so again, if I'm going to have to fight denials, which then slows down my cash flow for the next 4 to 6 weeks, because payers haven't, updated their systems to no longer require an authorization, then what we can do is trend those and say, hey, let's go back to the basics. Let's go back to what they originally needed from us. And let's just do it, even though they have said, hey, we're going to waive this for the next 60 days. I know as an organization, they're also, tracking cash flow, and every single day we're trying to look and see what that's going to be now that elective have been, discontinued, so to speak. I think we're also trying to keep track of what is that lost revenue. So how many services are being canceled or moved out, so at a later date we can report on that lost revenue. So just to kind of bring it home, nothing new other than just what I said at the very beginning, just trying to be as business as usual as we can be.
Great thoughts. Thank you, Samantha. And Sheila, we'll close with your thoughts on this topic.
I have to agree with Samantha. You control what you can. And even though we're preparing a spreadsheet and a library in order to dispute or appeal, we're not relying on that. We are also continuing our upfront processes. We're going through all those process norms and getting those authorizations, but it is difficult. So I expect down the line that we'll have to appeal and argue some of those out. We'll continue to monitor all the metrics that we can and look at scaling down or back due to the closed services if and when we get there. So far that hasn't happened, but it is something that I've tasked all of my management and supervisory staff to be mindful of and to keep on the back burner. What is your plan B and C, just in case? So I think that there's more to unfold. It's hard to predict what all those avenues might look like.
Yeah, I agree. I agree with both of you. We're only a few weeks into this, so I think there's still a lot of uncertainty ahead, but like you both said, we just have to control what we can control. I'm going to turn it over to Greg in just a moment. Before I do that, I did want to let everybody in the audience know that we're going to have some time for questions at the end. I've already gotten a few come in. So if you do think of anything, go ahead and enter that question into the tab in your GoToWebinar panel, and we'll open that up to our panelists at the very end. But before that, I would like to turn it over to Greg Greg, can you tell us a little bit about what PMMC is doing? As far as a revenue cycle service company, how are we responding to these recent changes, and what can we do to help?
Yeah, so we work with a number of the attendees on today's call, and we're similar to most healthcare providers in that we had to quickly shift to a work from home environment as well several weeks ago when North Carolina, Mecklenburg County, Charlotte region went to a shelter in place process. So anticipating that, we, similar to Samantha and Sheila, we tested the transition first by starting with a rotation of a third of our employees working from home each day to identify gaps for process improvement. We quickly identified and addressed similar issues. Most were minor, things like individuals having home PCs or laptops, but finding it helpful to have a dual monitor at home, similar to what they had at the office. So we had to make some arrangements to help our employees meet the needs of our clients. And we really provide two key services, software and some critical cash flow services as it relates to underpayment recovery. And as a software provider to hospitals, we still have to continue to do the normal things like monitoring daily data flow coming in from a contract management or an estimation standpoint. Our development team similarly has to continue to incorporate new reimbursement methodologies, maintaining enhancement schedules. We have to continue business as usual, and also being available to you guys, our clients, our customers, from a software support standpoint. So we made those arrangements. Our team's working from home. We're probably 95% of our team's working from home, with a few key employees in the office, if you will, from a software support standpoint. As it relates to our more critical cash flow service, looking at underpayments and helping hospitals collect on inactive accounts, we transitioned those team members to a work from home environment. Similarly, we worked through and have incorporated many of the workflow items that Samantha and Sheila both referenced as well. And that includes keeping specific team members in the office so that our collection process doesn't stop as it relates to printing, mailing, getting information out the door to payers from an appeal standpoint. And, we sort of view it as our clients need every dollar that can be collected right now. And obviously finding lost and written off money can have a significant impact on our clients' bottom line, just like having the software up and running in a consistent basis. We recognize what we do can often, translate to, $500,000, which may be small in the big picture, but that's can have a big impact today. So we certainly recognize we're all in this together. If there is anything your organization needs, please let us know. We obviously may not be able to directly have a solution for you guys as our clients, but we have a very large network that we can reach out to on your behalf, and certainly there to support you guys in any way possible.
Great. Thank you, Greg, for those thoughts. And then as we wrap up here, I would like to open it up to questions. I had a few come in during the session, so I'm going to start with those. But if anybody on the line thinks of anything, go ahead and enter those, and we'll go ahead and take those now. So one question is around payer response time, and we talked about this a little bit, but are payers starting to slow in their payments? And are you seeing any slower response to appeals at this time?
The only payer, this is Samantha, the only payer we've seen so far is Medicare. And like I said, the end result each week is still the same, but you'll see just a couple days where it's really low payments and really low claim processing. And then we have a really big remit where they pay, half of the claims out there. And so we're used to seeing Medicare, remits kind of split up each day. with the payments on the floor, but not quite like this. As far as the appeals, it's hard to say at this time. We've only been, remote about 2 weeks, and we have seen some appeals. I will say we have heard back from some. Some of our Medicaid managed care are a little slower. And on top of that, some of those payers even still required to be mailed in. So, of course, we'll continue to see those slow down. I think Sheila mentioned it earlier. It's probably our biggest thing right now is just getting someone on the phone. Humana, for the longest time last week, didn't have any callers available, and you had to request everything online. And so for the Blue Cross folks who are used to using Stat Chat all day, every day, when your wait time goes from 5 minutes to 30, we're still trying to control what we can control, but obviously the number of accounts and denials and things that we can work on a daily basis are slowed down. And so I say that to say I think our biggest thing is just getting someone on the phone. The wait time and appeals I feel like are coming, but I don't have a good handle since it's just been about 2 weeks if I've seen that slow down quite yet.
Okay. Any additional thoughts from you, Sheila, on that?
What I would say is that in terms of response time, turnaround cash was pretty decent for March, so we haven't really seen that, but I think it's coming in the next couple of weeks. In terms of response time, where we've really seen the slowdown is on the phone, getting a person, acknowledgement that items were received, or getting somebody on the phone to complete an authorization or to perform follow-up activity. That's where we've really seen the slowdown. And honestly, right now, I would take a 30-minute wait. We have seen some astronomical waits on the telephone. So I don't know what the difference would be. We're dealing with the same managed care payers, but I've seen some really large hold times.
Okay. This is a question this is more of a work from home related question. Do you all know what app you're being used to link calls from your home to your desk phones? I think someone talked about that.
Yeah, this is Samantha again. It's Jabber Client, and that is J-A-B as in boy, B as in boy, E-R. So our IT folks basically just got a list of all employees with their extension, and they were able to link from the cell phone their extension at work. So again, it's called the Jabber Client.
Awesome, thanks. Next question is around the Medicare accelerated payments. Is there a form for that, a form name, or a specific location where that information can be located?
Yes, we went to Palmetto. You'll have to go to the A and B MAC, and it's a very simple form, actually surprisingly simple. Found it on the Palmetto site, and I believe that Palmetto referenced it in a couple of the meetings that they hosted recently.
Okay, great. Thank you. And then we had a question around faxing. Can you briefly explain the Can you briefly explain the Epic faxing option?
So we actually have what we called Fax Press. And so the follow-up staff, and again, I think it is a cost, or they may give you a certain amount of free. Not all staff have it. They've had it for probably years, but basically AMED bought a certain amount of licenses. So it's actually not straight out of Epic, but what we can do is they can save the PDF out of Epic and fax it straight through Fax Press, and also receive those back. So it's like its own little fax number within their computer, but that was something that was put in prior, but I'm sure could be, purchased at this point so that the folks that are remoting from home can have that fax capability. But it is called Fax Press.
Okay, awesome. Thanks, Samantha. One more that just came in. What tool do you use to monitor denial trends And would you be able to quickly identify any new trends as a result of new work from home changes for both the facility and the payer? It's a good question.
So we're using I'm sorry, go ahead, Samantha.
I was just going to say that we actually just within our work queues and the denial rate within Epic is something that we track every single day. So if I come in today and Epic has a denial rate of 8.5, and then in the morning, my daily remits post, and all of a sudden that goes up to 15.5, I know whatever remits hit that morning, we have a problem. And then after that, we can go to the work queue. So if I'm seeing a Medicaid work queue have 50 accounts in there yesterday, we post a remit, and now all of a sudden I have 250. I can, one, pinpoint that, yes, we have a denial problem, and two, I can pinpoint it specifically to Medicaid. And so we use Epic to the best of our ability, and we've really done a lot of work with mapping denials, preventable, not preventable, spent a lot of time on that the past year or so. But really, we just utilize Epic since that denial rate is updated every single day.
Great. How about you, Sheila?
We use a variety of methods. For example, I look at Cleopatra and Alexandria reports to figure out if we have any new variances. We also have a lot of reports that we built out for denial management purposes, so we continue to monitor those as well. What I would recommend is follow those reports, the variance and/or denial reports that you already were using, whatever your system is, and just know, hopefully you've got a sense of the trending and tracking and can know when you see a change in your condition.
Great. Thank you both for that info. And we are coming up on an hour, so I think at this time we're going to start wrapping things up. Just some closing housekeeping items. We did record this session. I'm hopeful that the audio came through okay on the recorded version. So we'll be getting out the recorded session and the slides out to everyone on the call shortly, definitely by tomorrow. We've included contact information for both myself and Greg, and Samantha and Sheila have been nice enough to share their contact information as well. So we definitely want to support kind of an open community while we're all going through this. I think we can all benefit from helping each other out as we learn more and more each day. So with that, I'll turn it over to Greg for any additional closing thoughts.
Great, thanks, Brad, and certainly do appreciate you doing a terrific job today moderating today's virtual panel. And again, we want to thank Samantha and Sheila for their insight and willingness to share their experience. Obviously, both organizations seem to have had a terrific contingency plan in place for such a situation, and just terrific leadership to execute and manage under today's situation. Obviously, our industry is on the front lines. We see it every night, while procurement and clinical staff are the current headlines, and really they're the hands-on team members. We all know from a revenue cycle standpoint, the back office business tasks are key components to each organization's financial viability and success. If you found, for everyone on the call today, if you found today's session to be helpful, please let us know. If there are other topics that you think would be helpful, and really more importantly, if you're willing to share your experience with others, we're certainly willing to create and conduct this type of community forum for others to share. Obviously, I think we all probably made notes from comments that both Samantha and Sheila shared with us today. And it's often best to learn from others than to have to navigate alone. And again, we certainly are willing to help create and conduct this type of forum if you guys find it to be helpful. We're obviously all working through similar situations and challenges. They're not all exactly the same, and there is often not a perfect path forward, but hopefully we can find the best path forward as we continue to exchange ideas and share experiences And as I noted earlier, if there's anything your organization needs, if you hear of any specific items, please reach out, let us know. We'd be glad to help in any way. Doesn't mean we can actually fulfill it, but we certainly can work our network of contacts to help you guys as we all manage through this process together. So thanks again for everyone's attendance.
Thank you, Greg. Thank you, Samantha. Thank you, Sheila. And thank you, everyone, for attending today.